Alright, so let's focus on the cranial nerves to the eye a little bit. Specifically, we're going to talk about, do you remember which ones? It's cranial nerves 3, 4, and 6, and then obviously cranial nerve 2. The ocular motor, trochlear, and abducens nerves. We'll start with cranial nerve 3. Remember, it has multiple function. It innervates the eye muscles and it has parasympathetic function. There's 6 eye muscles. Cranial nerve 3 does 4 of them. Specifically the superior rectus. This first 3 are super easy to know. Superior rectus, inferior rectus, medial rectus functions are very easily. You already know the function from the name. Finally, there's the inferior oblique. That is harder to memorize. You're going to have to put a little more effort into it. It moves your eye up. So this one's kind of weird because the obliques are opposite, okay? It's inferior but moves your eye up, and it moves your eye laterally and externally rotates. Next, there's a parasympathetic that's traveling in your cranial nerve 3, and this one has a parasympathetic as a function to cause pupillary constriction. Remember that pupillary dilation is from the sympathetics because you need all that light when you're running for your life, and so obviously the opposite is pupillary constriction when you have parasympathetics. Now, the lesions to cranial nerve 3 then can be easily deduced by you look at the opposite of the function. But this is a little more tricky because we have the motor and the parasympathetics in cranial nerve 3. So peripherally are where the parasympathetics travel. Okay, parasympathetics travel there, and inside is where the motor innervation is. So your nature of damage to the cranial nerve will determine the defects that you're going to experience. If you had compression of the nerve, guess which one's going to go first? Something's pushing onto it, and then the first thing that's going to go is the parasympathetics. So then your patient will present with what is the answer? It's going to be pupillary dilation. There is no pupillary constriction, so the opposite happens and you have a pupillary dilation, and it's classically called a blown out pupil. The other way you can get damage to this nerve is through ischemia, and notably there's blood vessels in the periphery of the nerve. Actually, it's more like here. The periphery of the nerve, they have little branches inside. So if you have ischemia, what's going to go out first? Well, the answer is that the inside's going to go out first. That is the weakest blood supply. So your motor innervation is going to be lost first. And the way your eyes will be presenting is it's going to be down and out. And the reason for that will make a little more sense in a second. But if you're knocking out 4 of these muscles, the last 2 remaining muscles are going to be moving the eye however they want. And your eye is going to basically be in the position dictated by those remaining 2 muscles, which we're going to talk about in a second, but those make your eye go down and out. So I'm going to draw out the eyes, and they're going to be down. Let's say the left nerve got hit, so the eye will be down and out. The eyeball is here. This guy's eyeball, this normal eyeball, and this is the one ischemia. Due to ischemia, it's down and out. So the next nerve is cranial nerve 6. Cranial nerve 4 is this trochlear nerve. It innervates the superior oblique. Remember that the obliques were the ones that kind of non-intuitive. They move opposite. So the superior oblique will then move the eye inferiorly or down, as well as laterally and internally rotate. So this one's a little harder to guess, but a lesion to this nerve will then make your eyes have difficulty moving downward. Actually, I wrote down the wrong thing. Oh man. Oh, you know that I did write it right. The affected eye moves upward because your inferior oblique is responsible for moving your eye down. And specifically, these patients have difficulty looking down, something like going down the stairs. That's how they're going to present. Finally, it's cranial nerve 6, which is the abducens nerve. This one innervates the lateral rectus, so that's the last of the 6 muscles. I honestly just remember that the cranial nerve 4 does the superior oblique, cranial nerve 6 does the lateral rectus, and then cranial nerve 3 does everything else. Lateral rectus obviously then does lateral movement of the eyes. So damage would then, which way would, if your left eye was damaged and you were normally at rest, which way would your left eye deviate towards? At rest, it would be deviating medially because there's no lateral rectus to pull it, to balance it out. And this patient will have difficulty with lateral eye movement. Alright, so that's it for our cranial nerve eye damage. Specifically, and actually let me just show you. So this patient at rest, we said the left eye was damaged. Okay, DMG for damage. So this eye is normal, so looking straight ahead, but this one's going to be medial. It's going to be bugging out, okay? And then when we ask him to move his eye out, we're going to ask him to move it this way. So this eye is going to go this way. This would be a lateral movement of the eye, but his lateral rectus is knocked out. Okay, so this one got knocked out. Lateral rectus knocked out. So left eye stays here, it can't move. It should be here, but it's not. It's over here, and that's a abducens nerve palsy, or basically damaged cranial nerve 6. All right, that's that for our cranial nerves for the eye.